Welcome back for part 2 of Health Policy and Delivery Systems. In this section, we will begin by talking about the private sector and independent practice. Independent practice is part of the free market system. Fee-for-service, the hallmark of which is you get to choose the provider. Managed care health organizations have evolved since this original model, and prevention gains greater importance as we move forward. Nurse-managed centers are centers in which advanced practice nurses serve as primary care providers. This employs a multidisciplinary collaborative approach and often focuses on vulnerable populations. With regard to managed care in the private sector, managed healthcare emerged with the health maintenance organizations in the 1990s. These organizations were groups of providers who were contracted with HMOs. The idea was to provide comprehensive care for a prepaid price. The motivation and goal was to promote health and control costs. The managed care key elements, contrasting with private practice, are the imperative to control costs, regulating healthcare utilization. The primary care provider is the gatekeeper to the system and coordinates all the care. Payment is based on the network status. In network, the patient pays less. Out of network, the patient pays more. The capitation method of payment is employed in health maintenance organizations. The provider receives a fixed payment per enrollee per year. The provider then provides all necessary care to the enrollee. What this really is a shift in the risk from the insurance company to the providers as a whole. Again, the PCP is the gatekeeper. Specialists require a referral. Members may have co-pays, and members must use network providers. Medicare Advantage plans are HMO alternatives to traditional Medicare. Private sector IPAs and ACOs. IPAs are independent practice associations, physician organizations where the care for HMO members is in private practice offices. There are several models available. Now, the Accountable Care Organization, or ACO, has as its key components in the Affordable Care Act. This has not yet been fully in place, but is part of Medicare reform. The structure, however, is similar to HMOs, and the focus is on cost containment. Private sector concierge and hospitalists. The concierge medical practices are fairly new. There's a membership fee for enhanced healthcare services. This is typically an annual fee. These practices tend to have fewer patients, resulting in more time per patient. Holistic care, and I will say that this is actualized. Typically, concierge providers are accessible by higher income individuals. The typical household income is $100,000 or $125,000 to $250,000 per year, and the typical patient is at least 50 years or older. Secondly is the hospitalist movement. The hospitalist movement has been around for many years now. Hospitalists are typically physicians and advanced practice nurses who provide comprehensive hospital care with the aim of improving quality and safety of care. Now let's turn our attention to point of service and high deductible health insurance plans. Point of service plans, or POSs, are where the best benefits are received when people use in-network providers. Seeing a specialist may cost a bit more of a copay. Still, benefits for network providers exist, but these benefits are significantly reduced, so the patient pays a hefty amount. Now, high deductible health insurance plans are relatively inexpensive compared to other plans. However, there's a high annual out-of-pocket deductible. This might be suitable for healthy people where the monthly premium is lower. And then we have health savings accounts, and most of you are familiar with that since most of you are working people. Employers may contribute, but they do not have to contribute, but the employee sets aside pre-tax deposits. Withdrawals are allowed for health-related expenses like prescription copays, office copays, and deductibles. There are federal limits as to how much a person can set aside each year, and if you don't use it, you lose it at the end of the year. So let's look at healthcare financing. In terms of costs, we have a situation where costs are increasing due to multiple factors, and the cost of healthcare increases at a higher rate than the general cost of living. There is less time in the system for health promotion. The sources of financing include federal government Medicare and Medicaid, the Veterans Administration, which is federal, the state-funded programs such as Medicaid, CHIP, third-party payments from commercial insurance, employer-provided health plan benefits, and independent sources, as well as out-of-pocket deductibles, copays, and health savings accounts. There are also subsidies from the Affordable Care Act for those persons who have trouble affording health insurance and do not have access to it through their employer. Mechanisms for financing health care are rather complex. Independent practice with fee-for-service, physicians, advanced practice nurses, and other healthcare professionals are providers. Salaried providers, nurses, advanced practice nurses, and physicians who are paid a salary by their employer. The problem with this method is that overtime is uncompensated, and this can often lead to burnout from overwork. And then hourly compensation, which most hospitals and outpatient staff are classified as. The workers in this system are eligible for overtime. And then capitation as a concept is where a flat fee is provided usually per year, regardless of the services utilized. This encourages preventive care to keep people healthy and to minimize related healthcare costs. The downside, some individuals might make unnecessary visits. HMO sponsors this and bears some of the risk of illness, along with the providers who are capitated. So let's look at Medicare. It's a federal program. It's paid through taxes, and I say primarily because once a person reaches 65, Medicare is mandatory, and that's something I just learned recently. And although it's mandatory, there is a cost involved for each individual. Finances for Medicare are for people over 65 years old, the disabled, people with end-stage renal disease, and people in hospice. Now, Medicare has several parts, and you've probably heard of these. Medicare Part A covers inpatient care in hospitals, skilled nursing facilities, home health care, and hospice. Part B is supplementary and voluntary coverage, which pays for provider visits. Part D covers some pharmaceutical costs, and there are multiple plans available. The challenges are the continued growth of the elderly population. As the baby boomers reach their peak in the coming years, there will be a great number of people over the age of 65. And the risk is the depletion of Medicare Resources Trust Fund, which unfortunately the federal government has borrowed money from time and again. Not all services are covered under Medicaid, under Medicare. Some uncovered services can include eyeglasses, dental, and hearing aids. Now, Medicaid is an assistance program that's managed jointly by the federal government and state funds, so it's being contributed by two pots of money, if you will. The states have the right to determine who is eligible for Medicaid. This costs up to 50% of some state budgets because it's an open-ended program. And some states declined Medicaid expansion with the Affordable Care Act. As I said, the benefits vary by state, and it's available to certain low-income individuals, no age requirements, and families with children with a 5-year lifetime limit according to your text. Now let's look at the private sector PPO. The preferred provider organization is where you have contracted providers who deliver member services at pre-negotiated rates, and they agree to accept what is the usual and customary or allowable amount for whatever services they provide. So this saves the patient money. They may have a copay, but their costs are not astronomical. There is extra cost if known PPO providers are not used, it should say here. Copays by members are required at the time of visit. Prior authorization is often required for hospitalization or costly tests and procedures like MRIs. Approximately 52% of employer-sponsored plans are now PPOs. The Patient Protection and Affordable Care Act, or PPACA, I apologize for the slide error here. It didn't work quite right when I converted it to video. This is new healthcare federal reform law which was signed into effect in 2010. It is the single largest change in financing of the American healthcare system since Medicare and Medicaid. The focus on vulnerable populations is a component. Also, the idea is to have affordability, accessibility, and adequate financing of healthcare. It's designed to reduce the number of uninsured persons via expansions in Medicaid, and establishing subsidies. However, the U.S. Supreme Court upheld the Affordable Care Act in June of 2012, but there have been some changes secondary to the Trump presidency. The key features of the PPACA unfortunately lacks bipartisan support, and the changing political landscape can result in repeal or significant changes in the law. The positive sides include no exclusion for pre-existing conditions, health insurance being mandated for everyone, the marketplace exchange being established for insurance plans, and policies that must cover essential benefits like, for example, mental health benefits and substance abuse benefits. Medicaid may be expanded on subsidies, but this is dependent on whether the states agree or decline. This is the end of Part 2. Thank you for your attention. Please view Part 3 next for the conclusion of this module.